Um, Pass it over to Dr. Shah and then get back into the background. So Dr. Shah is one of our steering committee members and the co-chair of our patient advocacy committee. Take it away.
Thank you, Dr. Warner. I'm extremely delighted to present our moderator for the next panel on healthcare equity and patient engagement. So Dr. Joel Tsevat is a professor of medicine and Joaquin Seguroa Distinguished Chair of our center. He's director for Center of Research to Advance Community Health and PI of the Institutional CTSA KL2 Award. He holds a joint appointment in Department of Population Health and Internal Medicine at Dell Medical School, UT Austin. He's an alumnus of UT Austin, Long School of Medicine, T.H. Chan Harvard School of Public Health, and Tufts Medical Center. As a past president of Society for Medical Decision Making, he's recognized internationally in health-related quality of life research, in particular health status versus utility assessment, cost-effectiveness analysis, decision analysis, and spirituality or religion research. With over 175 peer-reviewed papers, reviews, book chapters, and editorials, and also as a PI on multiple federally funded grants from NIH, VA, and AHRQ. Dr. Tsevat has a career dedicated to population health and community-engaged research and service towards racial and social justice through addressing health outcomes, health inequities, promoting sustainability, acknowledging context, and respecting culture. He's a PI of the City of San Antonio Metropolitan Health District for COVID-19 Community Response Coalition, and is studying the impact of disease and priorities among San Antonians who have recovered from COVID-19. Dr. Tsevat, take it away.
Well, thank you very much, Dimpy. It's an honor to be asked to chair this session. And we want to make it as interactive as possible, so we purposely decided not to have slide presentations. But we have three distinguished panelists, Drs. Narjust Duma, Sonya Reid, and Corrie Painter, and I'll have them introduce themselves, Corrie Painter, I'm sorry, before they give their remarks. They're going to talk about some recent publications and also about some of the activities related to the Disparities Interest Group. I think one possible outcome for this session would be, as Dr. Pergam mentioned earlier, perhaps some kind of call to action and or maybe some kind of statement that we could construct regarding increasing diversity in research and in access to care. We were going to start with, again, a couple summaries of the recent publications. And Corrie, would you like to go first and talk about your paper?
Sure. Hi, everybody. Thanks so much to those of you who are joining us today to learn about the consortium and the work that we're all involved with. I'm part of the steering committee and really involved mostly at the axis of patient advocacy and the work that we're doing. What we're going to talk about today is deeply meaningful to me, and in my opinion, some of the most important things that we need to work on together as a community in order to improve the outcomes for people that have both cancer and COVID. I'm a cancer patient, not by training, and a scientist by training, and have been really wearing both hats as I've gone through this world of biomedical research and advocacy, and deeply committed to trying to help within that realm. So I'm going to just do a little bit of a summary of work that the consortium put out, led by Dr. Grievous. And this was just recently published in the Annals of Oncology, just last week or the week before. Previous work from the consortium and other cohorts have suggested that older age, male sex, smoking status, ECOG, presence of comorbidity, hematological malignancies, and active cancer are associated with more severe outcomes. And it's pretty significant. The estimates of 30-day mortality associated with COVID-19 for patients with cancer range from 13 to 33%. which is staggering when you compare it to the general population, where those the mortality 30-day mortality rate is about 0.5 to 2%. The CCC19, there's been a number of reports put out, but this particular report is significant in that there was almost 5,000 reports that were included in the analysis. Those reports were collected between March and November of 2020. And as a result of the robustness of this data set, we were able to perform a detailed analysis with statistical power to address many additional parameters than had been done in some of the previous work. It enabled us to study whether specific demographic characteristics, clinical factors, and laboratory measurements were associated with more severe COVID-19. So this analysis, there was almost 7,000 reports originally included, and then there was various reasons that there was attrition down to about 4,966 patients that were included in the analysis. And of those patients, 695 died within 30 days. Patients who died were older. Males had worse outcomes compared to females, and it was indicated by a greater proportion of males who received mechanical ventilation or died. Multivariable analysis revealed higher COVID-19 severity among patients older than 40, males, and non-Hispanic Black and Hispanic patients compared to non-Hispanic white patients. In addition, obesity, cardiovascular, and pulmonary comorbidities, renal disease, diabetes, worse ECOG, and hematological malignancies were associated with higher COVID severity. Active progressing cancer, as well as cytotoxic therapy and COVID-19 treatments, directed treatments, were also associated with severity. There's definitely some take homes there. Of note and of relevance to this particular panel is that there was higher COVID-19 severity for patients of non-Hispanic, non-white race and ethnicity, with a higher 30-day mortality for non-Hispanic Black patients, suggesting disparities in healthcare access, delivery, and research. And this is reminiscent of a report that Dr. Rivera, who was on the previous panel, had put out in October in Cancer Discovery. The title of this report was Utilization of COVID-19 Treatments and Clinical Outcomes Among Patients with Cancer, a COVID-19 and Cancer Consortium cohort study, where we examined the association of COVID-19 treatments with 30-day all-cause mortality and factors associated with treatment. The takeaway from me, at least, and why this is at the intersection of care, treatment, and disparities, is that remdesivir had numerically reduced mortality versus untreated controls. And it wasn't enough to reach statistical significance, but the numbers were there. And if you look at who received remdesivir in order to study, it was Black patients were approximately half as likely to receive remdesivir as white patients. And it's just disheartening that this is happening today. Today in the work that I do, my day job in advocacy, I think there's a tendency to talk about kind of historical mistrust and disparities, that focus on the history of where we've been. But this is like a clear indication of where we are right in the moment, like right now in medicine. And we have to do better. And I think that we have to put the gauntlet down in order to figure out how we come together as a community. And one of the things I love about the architecture of this is there are so many of us at so many different institutions across the world. I think that we here today have an opportunity to identify ways that we can do better. And one of the things I'm hoping we can surface here are steps that we can take as a community in order to do better by our patients. The end.
Thanks. Yeah, I mean, as I think we all realize now, COVID-19 is unfortunately a microcosm of health disparities in our country, both in terms of disease, prevalence and incidence, access to vaccinations and those kinds of things. But I think what you're pointing out now is maybe even access to treatments. Okay, so next, Dr. Sonya Reid, who is a breast oncologist at Vanderbilt, will talk about another study.
Hi. So I want to talk about the non-Hispanic Black versus non-Hispanic White paper that we are actually in the process of putting out. And I just want to preface that with what we have seen, right, since the COVID-19 pandemic. We have seen, this has highlighted COVID-19 racial disparities that is unfortunately strikingly similar to disparities that we have seen in cancer across racial and ethnic groups for decades. It is well known that non-Hispanic Black patients with cancer have a higher death rate compared to all other racial and ethnic groups. So with that in mind, we therefore chose to focus on evaluating clinical characteristics and outcomes among non-Hispanic Black patients with cancer and COVID-19 using the CCC19, which is a very diverse cohort with upwards of about 20% non-Hispanic Black patients, 15% Hispanic patients, et cetera. In this analysis, we enrolled, we had approximately 3,500 patients where you had about over 2,000 non-Hispanic White and 1,000 non-Hispanic Black patients. And what we saw from our analysis is that non-Hispanic Black patients had higher rates of higher COVID-19 severity and when we say COVID-19 severity, we mean higher rates of hospitalization, ICU admission, and mechanical ventilation use. And that is in addition to having higher 30-day mortality rates. And this is even after adjusting for demographic and clinical factors. This is highly disturbing because as we know, we have seen these in cancer, and now in this pandemic, that's even worse. What we're looking at is like staring us in our face, and the question is why? And it's clearly a very complex answer because we know that the factors that are driving some of these disparities complex, but I think they do likely overlap with some of the same factors that have been contributing to cancer health disparities, such as differences in such as social determinants of health. We know, for example, that minorities, especially racial minorities, usually have challenges with social distances, living in lower income apartments, higher number of occupants, and actually are more likely to be essential workers working in grocery stores and in hospital settings. They also have more pre-existing comorbid conditions, which puts them at a higher risk. I think, as Corrie mentioned, higher rates of obesity was seen in our analysis among, and that actually translated to higher COVID-19 severity and mortality among our non-Hispanic Black patients, but not among our non-Hispanic White patients. And that, again, plays into, we're dealing with different starting points in our patient population. We cannot forget access to care issues. We know there's inequity in access to quality healthcare, which I think is a key factor contributing to higher levels of underlying health conditions that increases the risk of severe COVID-19 and mortality. And I think Corrie made an excellent point just now with, we know from our analysis within CCC19 that non-Hispanic Black patients were less likely, to receive novel anti-COVID therapies, right? Such as remdesivir, compared to their non-Hispanic White counterparts. And that is just, again, one of these access issues that translate, I'm sure, to other areas of care that were not clearly studied within this analysis.
Great, thank you very much. And then last but not least is Dr. Narjust Duma, who's a thoracic oncologist in Wisconsin, and she's gonna brief us on what she's been up to with this committee consortium.
Hi, everyone. So there are two different aspects that we can talk about it. One is the OLA COVID study. That was a study that was led by my lab. The OLA COVID focuses on the effects of COVID-19 in Latin America. Most of the data from COVID-19 has come from the US, West Europe, and Asia. But the data from Latin America has been a little bit different. So we had a different approach for this study, which was a grassroots recruitment of oncologists to understand how the virus has affected their practice. This already limited resources environment. We have oncologists from Mexico all the way to Argentina. And the unique aspects of these studies is that we have recruitment at the country, instead of us coming to them and trying to, tell them this is how it's done. It's like we have local people recruiting the oncologists. We have, the survey was available in Spanish and Portuguese, which is also important. Because many of the surveys are done in English, and oncologists in Latin America, they don't feel comfortable answering the survey. So we have over 700 oncologists to complete the survey in a matter of 4 weeks. We learned that the access to telemedicine is significantly different in Latin America compared to the US. The frequency of telemedicine is lower, the comfort level. Many patients do experience changes in adjuvant therapy, neoadjuvant therapy. But something that was very significant in the study, which soon to be published, is supported therapy was significantly affected. There was reduced access to antiemetics, reduced aspects to colony like growth factors that affected treatments as well, because those medications were not getting to the country. A second part of all of COVID was to understand the experience of the oncologists. And around 30% of them were deployed to COVID floors. They were deployed to COVID wards. And some of them were tasked with responsibilities that they haven't done for years, and some of them decades. Some cancer hospitals in Mexico, they became COVID hospitals. And that made these oncologists become what we know in the US as hospitalists. The benefit of all of COVID is that allows to hear the voices of the oncologists, hematologists, surgical oncologists in Latin America, and to evaluate their degrees of burnout. And that would be the second part of the study. Associated with that, something important to cancer health disparities is that for physicians of color, 2020 was very challenging. We know about structural racism. We have faced many barriers since we became pre-med medical students, residents. We are often encountered with macroaggressions and more. But we had two pandemics, and one was, the COVID-19 pandemic, and also the racism and that we all know, but now more people have become aware of it. So in collaboration with COVID-19, we have launched a study that I hope many of you can participate to understand how the virus has affected all members of the consortium, their productivity, their clinical practice, and for the members of the consortium that are part of racial minorities to understand how the burden of the social events also add on. As Dr. Painter and Dr. Reid mentioned, COVID-19 just showed on a larger scale what many of us know. We know these disparities. And for many of us, regardless how many titles we have, or ethnicity or minority group, we precede us before anything, and we affect how we get care. So if that happens to us, we are physicians and academic centers, it just multiplies and it becomes more challenging for patients. And to finalize this, I want to take a few minutes to mention our migration and our farm workers. They kept the country running as they continued to work in the fields during the pandemic. There were still blueberries to be picked, there was still fruit, and many of them do not have a documentation status in the country. And to be clear, no human is illegal. And many of them also got diagnosed with COVID-19. And they will continue to work because they don't have a social support. They don't have insurance, many of them, or and access to care. So I think it's important to mention our farm workers that are immigrants and the ones that are no immigrants, because they experience different types of disparities and they're often left out for many studies. So thank you for listening. And if you want more information about all of COVID, please reach out, and I'm going to share the link to the survey in the chat.
Great. Could you also mention something about the disparities interest group within the CCC?
Yeah, so the disparities interest group started, I think, quite early, and it has been led by several people by different cohorts. So I'm part of the Hispanic cohort, but we all work together to evaluate the disparities. We meet frequently, and several manuscripts, including the one that Dr. Reid mentioned, is moving through production. He also has provided an environment, in my case, to meet with other oncology providers during these very hard times, to share some of the fears and just support each other morally. Because as a Latina, I have many family members that were affected by COVID-19, including myself. So, the fear of losing your abuelita with COVID-19. So the group is very productive in research, but also provides that moral support that you see the statistics, right? Like people like me are being affected the most with this virus. So I think If you're interested in joining the group, you are welcome. And we're a very good group, and we're very good with emails, I think.
Okay, so they can contact you if they want to join?
I think they have to contact the boss, but sure, they can CC me there too.
Great. Well, thanks for those remarks, everyone. You know, as we were discussing, preparing for this panel, we talked about the importance of being intentional to ensure adequate representation of, you know, underrepresented minorities in both in research and in access to care. And I wonder, some of you may have been involved in writing those post-acute sequelae of COVID, those past grants that were due like last week or this week. I can't even keep track of the days, actually Tuesday. And those were supposed to have a major community engagement component to them. And I'm wondering if any of you were involved with that, and if so, what kind of some of your strategies might have been to engage the community and in this type of research. I'm opening that up to anybody if anybody's been involved. I'm sure your institution submitted one or many of those. Okay. Well, I guess I can talk about ours and the ones that Dimpy and I worked on. As I said, these were huge grants, and they were, you were supposed to propose a cohort or two that you could study, and then you could propose 4 or 5 projects that you could propose to the consortium as well. And I'm assuming that most of these applications had at least some kind of community advisory committee included in them. But I would argue that that's not quite enough, just to have kind of a token group of people that you could get a letter of support from, because you really need, you know, bidirectional community engagement in these things. You need to have the community involved in formulating the questions, in planning the study design, in you know, the dissemination and implementation plan and all that. And so I think there are some, you know, I'm sure that the projects that were proposed to study this post-acute sequelae of COVID or long COVID were all over the translational research spectrum. But I think for any of the kinds of projects, whether you're planning to do, you know, genome sequencing or REDCap surveys or whatever it is, you really got to think about involving patients or community members from the very start. And so I'm just kind of I'm putting that out there for comment, or for maybe as a call to action, maybe to be thinking that way.
I really appreciate your words and the work that you're doing there. And I do want to say that in our patient advisory committee, this has been foundational in how we think, though we may not have perfect representation of the people who get both cancer and COVID. It is on like a leading thought of ours to make sure that we're doing right by people and messaging right and doing our outreach right. In terms of being able to have, you know, representation both within the patient advocacy committee, as well as the communities that we're trying to reach out to. I think for a long time, you know, just like historically, that was not appreciated. You know, it was not appreciated at all. And I think, you know, this past year, if anything if there can be any silver linings, I think having a robust dialogue where everybody has been part of the conversation has enabled people empowered to take a step back and realize maybe they need to be a little bit more silent, and maybe they need to elevate the voices of other people who are equally as talented and equally as important, but just have been held down by, you know, a system that has just not had equity top of mind. And so I think that leaves us with the opportunity to think about things just like this. How do we go about bringing diverse voices into the mix so that we can move forward responsibly and with more equity?
And I have to echo that because I think it's our responsibility and our duty to support and sponsor investigators of all backgrounds. The diversity has been proven over and over again to improve productivity in different parts outside of medicine, to increase ideas, to see problems with a different set of eyes. And it also makes us like better humans, physicians, researchers to work with people that have different ideas. And I use the example of cheese because I live in Wisconsin, but can you imagine eating the same type of cheese for the rest of your life? Like it will be your favorite type of cheese, right? But you're gonna eat it every day for the rest of your life. Let's just all have a cheese board with different diversity and not only racial, sexual orientation, backgrounds. Are you a first generation physician versus a fourth generation? And that we improve our research and we help us diversify our experiences. So no more one cheese, let's just have a cheese board with veggies and charcuterie, whatever you want, but it's time to diversify our patients, our advocates, and our researchers.
I love that. I'm never looking at cheese the same.
Somebody said, don't forget the wine, right? Sonya, do you have any experience with community advisory committees or, some better than others?
Definitely. I think, we can never think of all the questions and what matters to a patient most, because we just don't have their perspective. And as NJ said, sometimes it's not even that perspective. It's just that collective differences from just different experience. Bring that richness to our research study and our research design from the get-go, and not being an afterthought where we're like, we never thought of that. No patient would like this because patients don't, these patients just are not receptive to X or Y. And I think when you have that from the design, the study design, or even just from that discussion up front, it makes for a more robust analysis that actually matters to our patients, which is why we're doing this.
I can give a real clear example of the influence of patients in terms of study design. This is something in my day job, I work with an initiative called Count Me In through the Broad Institute of MIT and Harvard, where we do patient-partnered genomic studies. And when we launched our first project, we really thought we were doing right. We really actively tried to solicit a diverse representation of patients that helped us build out materials, but we didn't, and even me, who has been like the token patient, was guilty of finding token patients to really help us along. And I think that's one of the things you have to be so critical, not just of other people, but of yourself, if you're actually going to bring about change. And this was an instance where I was definitely guilty of not doing everything I could at that moment in time to bring about representation in order to help guide us in the right way, to have people looking at our project say, I see myself in there, right? So over that first year, we convened a group of the amazing advocates. They were 5 Black stage 4 metastatic breast cancer advocates, and we brought them to the Broad and we spent a day with them. And one of the things we did during the day was we showed them the materials we had built out with predominantly white patients. And we said, these are our trifolds and this is our website. And what do you think? And they said, I think white people get this disease. And we're like, wait a minute, we specifically made this, like it was a silhouette on purpose, like so that it would not necessarily be. And they're like, yeah, I can see why I think that, but no, this is a white person. And then they went through and like detailed what they were seeing, which I would never see as like a middle-aged white lady. I just wouldn't, you know what I mean? And we had to have other people see things through their eyes and be willing to also, and comfortable and feel safe enough to like give us that feedback so that we could change the look and the feel and the design to better and accurately represent. And so I think that, there were so many lessons learned there, both in terms of just you can't just invite people to the table. You can't do that. You have to make that table a place where people will sit down and see that cheese board. You have to make it so that they feel welcome once they're there. You have to, you know what I mean? And so, this goes for gender and race and every single thing. I have been the one woman at the table feeling really awkward, like, should I clean the table now? And you can't do it that way. You have to make it so that people feel like they belong there every bit as much as everybody else that's there. And so I think we need to not just say we need to increase numbers or we need to increase representation. I think what we also have to do is make sure we're doing that in a responsible way where everybody that is included feels like they really belong there.
One analogy I heard was it's more than just sending an invitation to the party. It's actually asking them to dance.
Oh, I like that. That's good.
There's a lot of misinformation and disinformation going around, and maybe more so in some certain communities. And that may lead to, what's called vaccine hesitancy. I like the term vaccine confidence more than vaccine hesitancy. But are there ways to combat misinformation and disinformation? And by disinformation, I mean intentional misinformation, as opposed to just bad information.
So I'm gonna, sorry.
Yeah, go ahead, please.
I'm gonna speak for the Hispanic community, because at the beginning, a lot of materials were in English. And like my abuelita will not understand that. And that's something that we forget, that a lot of people in the country do not speak English as their first tongue, or don't speak English, period. And for the beginning of the pandemic, many things were just in one language. And with the vaccination has happened. So I think it's important that things are included in more than one language. And they're not just literally translated, but their cultural aspects are taken into account. I just reviewed a brochure that was like a Google translation into Spanish, and it made no sense. So we have to make sure materials are available in all languages, and also that we reach the different subgroups where they're at, right? Because there's faith-related communication. We can work with churches, but there's some groups that may not go to the church. So we have to go to them in the appropriate language. And also, I have to advocate that un poquito de español is not enough to explain a vaccine. Like, say that you know how to say dolor and how to order a beer and a beach in Cancun, that is not enough Spanish to explain somebody why they need the vaccine. And then the patient gets labeled as not compliant or not understanding, when in fact your very broken Spanish was used for that. And you feel great because you didn't need the interpreter. So I advocate, one, for materials to be in Spanish, and second, to use interpreters. If you speak like a third grader Spanish, it's not enough to explain the importance of this vaccine. And to use people that look familiar to this Hispanic community. You can use Don Francisco. I don't know if you guys don't know, but he's like a big person in our community to generate trust. Like, people that our community doesn't know, they're not going to trust it about vaccine. Like, it's great to see Michelle Obama talking about it, but for the Hispanic community, we need somebody that, Gloria Stefan, I can keep giving you names, but yeah.
Well, and we have a large Hispanic community in Texas, obviously, and we're finding that community health workers are good advocates for providing health information and for, dispelling some myths and those kinds of things. So they don't have to be stars, they don't have to be movie stars or whatever, but if they should, I agree with you, they should be from the community that you're trying to, you're trying to get the information to. Okay. Other comments from the other participants regarding this, their experiences or issues that they think we should be addressing related to health disparities, patient engagement?
I just wanted to add something related to the vaccine hesitancy that you mentioned. I think we have to understand and respect that there is a mistrust over decades in certain communities. And I think that's kind of where a lot of us need to start, is really to be silent and ask someone, why is it that you do not want this vaccine? Because that may differ, even in one household. Those reasoning, depending on the age and what you have heard, may differ. And I think a lot of times, if we take the time to truly ask our patients, why is it that you do not want this vaccine? And try to overcome those specific barriers depending on what their feedback is, we would go a lot further along this journey and really trying to increase the vaccine uptake. Because I think a lot of times we just disregard, yeah, that was a long time ago, get over it. And some people, like, that still sometimes is a fresh wound because we don't know what mistrust they had to deal with maybe yesterday in another scenario. So I think we really have to just be intentional about listening to our patients and understand that their whys may look different.
Yep. So true. So we have a few more minutes. I think Jeremy's giving us till 12:30. Do people think it would be a good idea to issue some kind of statement or formal call to action from this group that we could disseminate, broadly?
Abby, one thing I can speak on behalf of our steering committee is that we know we need better representation. And, after last summer, we put a call out to the consortium asking folks, if they had recommendations or if they themselves wanted to, talk with us more about this. And we didn't get a lot of traction. And it could very, very well have been the way we worded it, the way we disseminated it, and who we are, and how we are represented right now. And we need help, we need help to make sure that we can grow as a steering committee and as an organization to address a lot of the things that we surface today that, we're talking about, but again, are not new and have been ongoing, and we can't be part of the problem, and I think that in order to make sure we're not part of the problem, we have to have better representation. So my call to action is to just see if we could explore that space so that we could bring additional people into the fold.
I don't know, do you have patients with COVID and cancer as part of this consortium?
Well, we do have a patient, we do have a patient advocacy committee, but I'm talking about at the steering committee level also.
Okay. I see one recommendation for a white paper summarizing the retreat. Okay. So I guess I'd like to turn it back to either Jeremy or Sanjay for any closing remarks for the retreat.
Thank you. Thank you, everybody. Thank you for this panel. I'm just gonna, well, first of all, sure, let's write a white paper, either about the entire retreat or, this panel in particular. I think, we started unpacking some real and ongoing issues here. But yeah, let's think about what that might look like.